Thank you, Professor Bhatia. Good morning, everyone. And I welcome you all on behalf of the Urology Department. Today, we are going to touch a very important tumor from the point of view of children and the child health care. And this is one tumor which it's constantly evolving in dynamic classifications. There are many groups in the world which have claimed that the treatment strategies from one group are better than the other group. So as this presentation goes on, you all have to be listening very carefully because the terms like COG, PSYOP and all will come. And the management, as you will see from the department, how it has logically evolved along with the evolution in the system. I know this is a tricky topic because as we know about the tumor suppressor gene and its origin from the retinoblastoma, this is one of the first tumors where the genetic classification or the use of genetics and molecular biology came into tumor management at its initial point only. And now we know that we have a lot of understanding in all the tumors. So friends, as we go along, you all have to listen carefully, understand it, because as the topic says, it's impact of the subject, source and support system. So how and why there has been a deviation or there has been a combination of the classification of different groups and how we have evolved our own system based on the evidence base. So that understanding is important, and then you will have you can have a lot of questions. So may I invite Professor Ansari to set the ball rolling. Professor Ansari, please.
Thank you very much. Very rightly introduced, sir. As we are aware that Wilms tumor is one of the commonest tumor of the preschool age. And this is another tumor in urology besides the testicular tumor, which has enjoyed a very legacy of excellent success story with excellent outcome in terms of its oncological control. But this success story basically is confined to mainly the, as Anisa rightly mentioned, to the American and the European cooperative groups and some of the developed countries. But unfortunately, we are facing a lot of oncological as well as non-oncological barriers to reach to the same success point. And we have touched some of these issues in managing these children. So we have divided our experience into part 2. One is the background and the biology of Wilms tumor, and it will be followed by results and comparison with the rest of the world. So part 1 will be done by Dr. Puneet, and part 2's results and the discussion will be taken care by Dr. Prabhu Karnakaran, our fellow in Pediatricology. So all to Dr. Puneet.
Good morning, respected teachers and colleagues. Today we'll be presenting our experience about the Wilms tumor management, which is experience of about over 2 decades in our institute. Coming to the introduction, we know Wilms tumor is the most common adult, sorry. Wilms tumor is the most common pediatric abdominal tumor, which comprises about 6% of the pediatric tumors. It is the 5th most common malignancy of the childhood. As it is reported in the Western literature, it is about 90% comes under the 3 years of age group, and it is also reported more in the females. And about 5 to 7% comprises in the bilateral tumors, and usually they present 1 year earlier. When it comes to the developing countries, there is usually a lack of cancer registries, which leads to paucity of data, and whatever the data is available is also of poor quality. And in the developing countries, we do face specific challenges like late presentation, poor nutritional status of the kid, and a low socioeconomic status of the parents, and low educational levels, which eventually impact on the outcomes of the disease. When you look at the biology, majority of the cases are sporadic tumors which comprises of 90%, and approximately 10% can have associated congenital malformation either as a single entity or as a part of the syndromes, mainly the Wager syndrome, Dennis-Test syndromes, and Beckwith-Weidman syndrome. When you look at the pathology, tumor is usually a large solitary well-circumscribed friable mass, and usually calcifications are not seen as seen in the neuroblastoma. When you look at the histopathology, classically they have been described as a triphasic embryonal neoplasm, which mainly comprises epithelial, blastomal, and stromal. And epithelial components is comprises of tubules and the glomeruli. Components and composition of these three components leads to the different presentations. What are the types of patterns they can present is most commonly it presents with the mixed of all these three, epithelial, blastomal, and stromal. And blastomal predominance can be seen in 39%, epithelial predominance in 18%, and stromal predominant in 1%. What is the significance of this histological pattern? The points of COG and SOP will come later. With respect to the pathological stages, they are divided into two categories as per the COG. One is favorable and another one is unfavorable. Unfavorable if there is any part of anaplasia, whether it is a focal or diffuse anaplasia, it forms an unfavorable histology. Whereas the SOAP classifies these tumors into low, intermediate, and high risk. And we can understand low risk tumors comprises mainly of benign lesions which are having more of necrotic tissues, and intermediate can have the components like either epithelial, stromal, or mixed type, or it can have also focal anaplasia also. So where the high risk is usually have the blastomal component, diffuse anaplasia, and other two varieties, that is clear cell sarcoma and rhabdoid tumor of the kidney. All these classification were done under the umbrella protocol by SOAP. So what is the significance of anaplasia in Wilms tumor? It is usually seen in about 5 to 10% of the Wilms tumor, and usually patients are older than with the non-anaplastic tumors, like they may present with 1 or 2 years later. So it is usually also associated with the blastomal elements rather than the epithelial and stromal elements. So how do you say it is either focal or diffuse? Because focal is relatively better than the diffuse one. So if it is focal, it will be said up to 2 foci up to 15 mm in size in SOAP, or up to 4 foci up to 20 mm in case of COG. Further extending the anaplasia importance, if it is usually associated with TP53 mutation, it has a less favorable prognosis. And in case of diffuse anaplasia, it is more resistant to the chemotherapy and leads to the relapse and fatal outcome in advanced stage diseases like 3 and 4 stage. How do they present? We heard in the clinic that so most of these kids will present with the mother saying that she noticed the swelling in the abdomen while giving birth to the kid, and it may be associated with abdominal pain because of the large size of the mass, and can be associated with fever. And if there is any involvement of the PCS, it can lead to hematuria. And approximately 10% of the cases can be have syndromic approaches, as we seen previously. It can be either isolated congenital anomalies or as a syndromes like Wager syndrome, Dennis-Test, or Beckwith-Weidman syndrome. So how do we work up once the kids come to our clinic? So we must take the history and any significant familial history. And after the examination, especially we should look for any congenital anomalies like hypospadias or any features of mental retardation and growth retardation. In the workup, apart from the routine workup, we should concentrate on the creatine because further baby needs nephrectomy, chemotherapy, and radiotherapy. We should monitor this serum creatinine level, and we should also look for the proteinuria in urine routine examination, which is usually seen in Dennis-Test syndrome. So as an imaging part, so apart from the ultrasonography of the abdomen, we must get the contrast enhanced CT scan of the whole abdomen to look for the size of the mass and the extent of the mass, local infiltration, look for the lymph node status and surrounding organ involvement. And we must also get an CT chest, look for the metastasis. So even here also, SOAP and COG has slight difference in the investigation protocol, whereas COG advocates for the CT abdomen, and but SOAG advocates for the MRI abdomen, and both the protocols advocates for the CT chest. The main difference is about the cytogenetics. Of the late in the last decade, COG has adopted the cytogenetics in its protocol during the workup and the management, which we will be subsequently discussing. So what is the importance of cytogenetics with respect to the Wilms tumor? We know most of the malignancies of the late, whether it is in pediatric, adult, or geriatric, we are more in looking at in the genetic basis, which can affect our decision process, and so in selecting the further chemotherapy or immunotherapy. So it is also true in case of Wilms tumor. So in the previous studies, last 2 decades, it has shown that in the cytogenetic studies, usually Wilms tumor is associated with 1p and 16q deletion. They are known to be elevated risk of relapse and fatal outcome. So doing this cytogenetics will allow us to stratify our treatment and to prognosticate the child. And it is also helpful in to diagnose the different syndromes associated with the Wilms tumor. So in the management part and the prognosis part, it is seen that loss of heterogeneity of the chromosome 1p and 16q is an adverse effect prognostic factor in favorable histology group. And also it has been shown to have an increased risk of tumor relapse and the mortality. It is mainly in case of the favorable histology. And another important point is, if there is either of the locus is involved, it is more frequently associated with the stage 1 and stage 2 of the favorable histology group. And if it is both the regions are involved, it is usually associated with the advanced disease like stage 3 and stage 4. So how it is going to help us, loss of heterogeneity either in the 1p or 16q. So in the, as I said, so COG has studied the many genes from genetic models. In that they found that, and comparing with the different treatment protocols, it is known that we need to intensify our treatment either in adding an extra chemotherapeutic agent in case of if there is any loss of heterogeneity in either 1p or 16q. So this is how we are going to alter our treatment based on the genetic studies. Usually we, for stage 1, stage 2, as an adjuvant chemotherapy or neoadjuvant, we usually give 2-drug regimen, that is vincristine and actinomycin. If there is any loss of heterogeneity, we must add another agent, that is doxorubicin, in the stage 1 and stage 2. Whereas in advanced disease like stage 3 and stage 4, routinely we follow 3-drug regimen, that is vincristine, actinomycin, and doxorubicin. Whereas if there is any LOH, we must add another 2 drugs, that is cyclophosphamide and etoposide. Thereby we are intensifying our treatment, which obviously affects the outcomes. So coming to the general management of the Wilms tumor. So it is said that it is done that, so it is always a multimodality treatment. Whenever a case of Wilms tumor comes, it is not simple one stream associated management. It is always multimodality. We must undergo surgery, and he may require adjuvant chemotherapy or neoadjuvant chemotherapy. Subsequently, in advanced diseases, kid may need radiotherapy also. It is all based on the stage of the disease and whether on histology, whether there is a component of unfavorable component in as a part of anaplasia. So since it is a multimodality, there are many groups who have been formed in the last century, in the late 19th. Mainly in the North America and Canada, they were following the National Wilms Tumor Group, which looked into the diagnosis, management, and the protocol. And in the Europe countries, they were following the SOAP, were morely focused on the European countries. And also previously in United Kingdom, there were another group, UKCCSG. So whereas we do have Indian Wilms Tumor Study Group in India. But after late, in the last decade, most of them have been merged into either SOAP or COG. So what is the main difference between the COG and SOAP? COG primarily advocates for the upfront nephrectomy, which helps in further staging, the proper staging, and looking at the histopathology, we can further decide the adjuvant protocol. Whereas in SOAP, they first give the neoadjuvant chemotherapy for 4 to 6 cycles, then they will assess and they will go for the nephrectomy. They usually differ in aspect to treatment and risk stratification, as we seen before. This is the risk stratification, how pathologically, how they do COG and SOAP. So after late, mainly even though there are 2 groups, their main focus is on to decrease the intensity of the therapy and to prevent the late sequelae of the treatment while maintaining the excellent overall survival. Even though they are different in their approaches, the outcomes are the overall survival reported is almost similar in both the groups. That is in the stage 1, 98%, and the stage 2, 96% overall survival, stage 3, 95%, and the stage 4, 90%. So what is our practice? Before 2005, based on the discretion of the surgeon and the resectability of the mass, we were either following the SOP or NWTS protocol. So after 2005, we have an uniform protocol as per the UKCC SG group. So in that case, when the kid comes to us, if we feel it is stage 1, stage 2 based on the imaging, we'll go after the biopsy, we'll go for the nephrectomy. And if it is stage 3 and stage 4, like lymph node involvement, or in stage 4 lung involvement, so we give the after the biopsy, we give neoadjuvant chemotherapy followed by nephrectomy, and we add the adjuvant chemotherapy. What is the current advocate of the COG chemotherapy? In stage 1 and stage 2, if they just less than 2 years and the small tumor less than 550 gram, the nephrectomy will suffice. If it is stage 1 and 2 and the rest of the tumors and there is no LOH, you must give 2 drug regimen, that is vincristine and dactinomycin for 14 weeks. And if it is there is any LOH, you must add doxorubicin to it. Whether it is in stage 3, like some tumor is remnant or lymph node is positive and there is no LOH, we give 3 drug regimen. And if there is an LOH, usually it is advocated to follow the kidney study protocol, or usually we give the 3 drug regimen. And in stage 4 also, we must give the 3 drug regimen and follow it up. After 6 weeks, if there is still persistent lung nodules, kid should undergo lung irradiation for the lesions. And the importance of radiotherapy comes in terms of the timing. So it is noted in NWTS 1 and 2 that most of the unfavorable histology, if there is any delay in the treatment behind 10 years of the nephrectomy, there is higher risk of local recurrence. This is where we must time the radiotherapy as early as possible. Otherwise, it will have an untoward effects. So, but it is not so unfavorable. Even if you delay like around 8 to 10 days or so, it doesn't affect the outcome much. And note on the bilateral Wilms tumor, if there is a bilateral mass, we must, after the biopsy, we must give neoadjuvant chemotherapy for 6 weeks and reassess with the imaging. If there is any shrinkage or we can see that it is resectable, we usually advocate nephron sparing surgery followed by chemotherapy. If there is no shrinkage or the tumor is increasing, we can continue chemotherapy, neoadjuvant chemotherapy for another 6 weeks and again reassess for the nephron sparing surgery. So where do we usually advocate the nephron sparing surgery? Historically, it is usually done in case of the single functioning kidney, or there is a bilateral Wilms as shown in the previous slide, or if it is associated with any syndromes like Beckwith-Weidman, Vagar, or Dennis-Dash, there is an increased risk of nephrogenic rest in these syndromes. So we must concentrate on the nephron sparing surgery rather than going for the radical one. But after late, in the last 1 decade, even the COG is advocating to go for the nephron sparing surgery in unilateral and non-syndromic cases if the tumor is small, like 1/3 of the kidney, and there is no PCS involvement, and there is no renal vein or IVC thrombus, and there is no lymph node involvement. So we are just showing our 2 cases which we have done the nephron sparing surgery, because it is quite interesting, because majority, more than 90 to 95% of the surgeons even don't have intent to do the nephron sparing surgery. So we have 2 interesting cases which we are showing. This is a 3-year kid with a right abdominal mass, which was about 9 to 7 centimeter. After the neoadjuvant, it has downsized it to around 5 centimeter, and we have done the partial nephrectomy. And this is another case where we have dealt the tumor with the robot. So it is about, in the presentation, about the size of the tumor was around 8 centimeter. After the neoadjuvant therapy, it has come down to 4 centimeter, and we dealt with it the left robotic partial nephrectomy. And with this, so we'll be sharing our experience over the almost 2 decades, how we are dealing with and what are the outcomes of our management. And I invite our pediatric urology fellow, Dr. Prabhu sir, to continue. Thank you.
Thank you, Dr. Puneet. So here is our study experience. That is the study period of 15 years in which the demographical, clinical, and pathological characters of the tumor has been considered, and outcomes of the modality of the treatment and challenges faced during the treatment of Wilms are being considered and drafted. And here is the data analysis. The data analysis is being done under the 3 headings: the subject, source, and the support. Coming to the subject, it is about the age, sex, and nutrition and outcomes of the modalities of the treatment. Coming to the source, it is about the literacy, income, and employment of the parents. In support, the cost of the treatment and state sponsorship and oncological support is being taken into consideration. Our treatment protocol has been clearly defined by the previous speaker. When the child presents with a Wilms tumor or renal mass, after initial clinical and radiological evaluation, the child undergoes a core needle biopsy, and depending on the stage of the tumor, either the child undergoes upfront nephrectomy in stage 1 and 2, and in stage 3 and more, the child undergoes neoadjuvant chemotherapy, and all these children will undergo an adjuvant chemotherapy after this principle is being followed. And the follow-up is, we keep the close follow-up in these children for the initial 2 years of age, 2 years, that is 3 monthly follow-up in the initial 2 years, thereafter 6 monthly follow-up. The recurrences are dealt with the second-line chemotherapy, which is an ICE regimen, which includes ifosfamide, carboplatin, and etoposide. The results are also drafted in these three headings. Coming to the subject per se, we had around totally 60 patients in which the male to female ratio was 2:1, and the late presentations were common in our patients. 50% of our patients have presented after the age of 5. Coming to the weight percentile, 32% had wasting, 39% had stanting, and nutritional status being assessed based on the mid-arm circumference, tricep skin fold thickness, and albumin levels. And we also noticed that there was almost 64% of the children presented to us were undernourished. And coming to the clinico-pathological features, already been briefed by the previous speaker, and most common feature being lump, followed by pain, hematuria, and fever. And in our series, we also had 12% of the patients associated with some congenital anomalies, along with the syndromes that is already clearly defined by the previous speaker, Dr. Puneet. And we had the tumors presenting to us were really large, and we had the range of 5 to 23 centimeters, but a mean size of 10 centimeters. Coming to the stage-wise distribution, half of the patients were fitting into the stage 1, the rest of the stage 2 fitted into the quarter of the patients, and stage 3, 4, 5 fitted into the rest of the quarter. Coming to the histopathological characters, the 85% of the children had favorable histology, and 15% of the children had unfavorable histology. And cytogenetics has been described by the previous speaker, like it's of paramount importance to define the chemotherapy later on. And we started the cytogenetics only recently, and we had about, that is in 2020, and we had about 6 patients in which we have seen the 1p and 16q loss of the deletions. So the total number of patients were 60 in our series. The total number of patients were 60, on which 38 of them underwent upfront surgery, and 22 of them was started on neoadjuvant chemotherapy, of which 12 responded partially and 5 had no response, and rest of the 5 had in the rest of the 5, 3 of them had been lost to follow-up and 2 expired during the treatment. Coming to the survival rates, and a mean follow-up of 70 months, the estimated 5-year survival rate ranged from 90 to 50 depending on the stage of the tumor. The overall survival remained around 72%, whereas the event-free survival remained around 67%. The recurrence was noted in 5 patients, in which we have initiated the second-line chemotherapy, but the 5-year survival rate in these children was not great. It was only at about 20%. Education status of the parents. You can see only 1/3 of the parents have attended the school. 1/3 of the parents did not attend the school, and only 50% of their children could complete the treatment. Whereas the education level of the mothers was interesting, in which 30% of the mothers had studied intermediate course, and 85% of their children could complete the treatment, which in short, the complaints of the treatment was great when the mother's education was good. Coming to the income, 60% of our families, the patient families, did not have a permanent source of the income, but in the rest of them, the income was to the tune of 20 to 30,000 per month per family. There was significant amount of loss of working days for the parents accounted to 110 days in our series. And 2/3 of the patients in our series belong to lower middle to lower class. The impact of socioeconomical class on the treatment compliance is almost directly proportional. That is, upper the class, the more compliant were the patients and they could complete the treatment. Coming to the support system, the average cost of the hospital stay during the surgery was around 43,000. For the chemotherapy, it ranged around 1.2 lakhs to 2 lakhs. 2 lakhs, sorry. And fortunately, 80% of our patients could receive some financial assistance from the state, from the schemes like Kamadhenu and Ayushman Bharat. And amongst this 90% of this 80% of the people have completed the treatment course within the stipulated time when they was being sponsored. But we have to look at the overall, looking at the overall picture, 24% of the patients could not complete the chemotherapy within stipulated time because of lack of finances. This added to the significant lag in the chemotherapy, thereby having a significant impact in the overall survival of the patient. We don't have a pediatric medical oncology support in our institute. That is why we have given the chemotherapy in almost 95% of the patients, and we have taken the help of Department of Hematology whenever needed. And 5% of the patient is being treated from KGMC Lucknow in the initial part of the study. We do have a radiation oncology support, but the biggest barrier here is the time. That is, as pointed out by the previous speaker, the biggest barrier here is the time that you should initiate the radiotherapy within 10 to 14 days of your surgery. That is why we have taken the multi-institutional help, that we have referred the patients to the adjacent institute for the radiotherapy. But we had a significant limitation here as well. Not all the radiotherapy units around were acquainted to pediatric age group. And despite all our efforts, not all the patients could be started upon radiotherapy within the 10 days of surgery. But the discussion is also plotted against the same parameters. Coming to the PKs of the presentation, 90% of the in global tumor registry data, 90% of the patients presented within the age of 2 to 3, whereas in our series, the presentation was late and 50% of the patient presented after 5 years of age. And this, with a large tumor size and with advanced disease, this significantly affected the overall outcome of the patient. The male to female ratio in our study was 2:1, but whereas in global tumor registry, it is 1:1. And there is with a slight female preponderance. The significant difference here and in the male to female ratio here, could be the possible attributes for this is either the genetic or epigenetic nature of the tumor per se, or the female children are being ignored, like in any other chronic illnesses, in the background setting of poor socioeconomical status. Coming to the nutritional factors, 64% of them were undernourished and 39 showed wasting and stunting, whereas the study supporting the similar context also point that acute nutrition is proportional to the tumor size in Wilms, and acute nutrition in Wilms is way higher than the community controls in the developing countries. Coming to our survival rates, the overall survival in stage 1 and 2 is comparable to that of the world literature, whereas in stage 3 and 4, it is on par with that of the developing countries, but definitely inferior when compared to the Western literature, the Western study groups, that is NWTS and CO. And the possible the factors contributing for the low survival rate, there are definite interplay of multiple factors, that is tumor-related factors, the tumor biology-related factors, and treatment-related factors, and socioeconomic factors. And most important of all of them is socioeconomic factors, in which the treatment affordability was a primary reason, and refusal of treatment. For example, if the child had a single episode of URI during the course of chemotherapy, there's a significant refusal for the treatment for the next cycle, and that led to the abandonment. the literature supporting here also says that the childhood renal tumors the incidence of childhood renal tumors are not associated with economical status, but mortality is. When the mortality is higher in lower economic group. Coming to the education of the parents, this is a significant risk factor for the child mortality. Lower the education, lower is the level of awareness, and they present late with advanced disease along with malnutrition. All this process augment the process of failure to complete the treatment. Here we had in our study, we had around 50 patients presenting after 5 years of age, and 64 presented to us were undernourished. Coming to the compiling this education status, higher the education, particularly of the mother, higher the education, higher was the compliance, the better was the compliance. Lancet publication in 2021 also supports the fact that the social support and awareness programs would lead to improvement of the survival. In families dwelling with lower education. The cost, so far there is no data in specific to the cost in Wilms tumor, but there are too many number of studies supporting the fact that lower the cost of the treatment, higher the financial support from the state, has a better compliance to the treatment and outcome of the patient. But the financial assistance from the government has a limitation, that is that assistance is limited to the hospital, and the logistic aspects like transportation, loss of job hours, and food is not being covered under the government aided financial schemes. Pediatric medical oncologist plays a pivotal role in tumor board. In the tumor board, they help in planning chemotherapy in the tumor board, and the presence of a pediatric medical oncologist enhances the comprehensive care of the patient because they are from the pediatric background. This is definitely a lacuna in our setup. Then how do we further improvise the oncological care in this setup is by instituting a centralized tumor board of our own institute, or in the digital era, making use of a virtual tumor board instituted by the expert institutes like Tata Medical Center, or we can have a twinning programs in which you have a pediatric medical oncologist. We can collaborate with the institute and deliver the care to our patients. A pediatric radiation oncologist, they also play an important role in the tumor board. They tailor the radiotherapy based on the size and need of the patient. And currently, we don't have a dedicated subunit for pediatrics. And the biggest problem here is we need to initiate the chemotherapy within 10 days. So we took a multi-institutional approach to help our patients. WHO has classified different settings for care providers for Wilms, in which it has classified from 0 to 3. And here, 25% of our patients has needed this the setting of 2 or 3, this intermediate or state-of-art care to sail through the entire course of the treatment. And to conclude, I would like to say the management of Wilms tumor in our country, particularly a resource-constrained nation like ours, need to be multidimensional rather than conventional, a multimodal way. What is multidimensional? It is enhancing the awareness of the patient and getting the finances from the state, and getting the multimodality treatment intact, that is with all these experts, constitute a multidimensional approach to yield the better outcomes in this patient. Though our patients present different, and they also deserve the best treatment, and which is not possible, particularly in cases like Wilms, which has got a very good prognosis. So without all this department support, it would have not been possible. We'd like to thank you for the opportunity. Thank you.